Good afternoon, everybody, and thank you for joining us for our CHEST Journal Club of the month of September. Today, we have our authors from the new lung cancer screening guideline that was published in CHEST this month. I am Alice Gallo. I'm an intensivist at Mayo Clinic in Rochester, and I'm one of the social media editors for CHEST. I'm joined today by my colleague, Vineesha Arelli.
Hello, everyone. How are you?
Dr. Mazzone, could you introduce yourself?
Sure, I'm Peter Mazzone. I'm a pulmonologist, work at the Cleveland Clinic in Cleveland, Ohio. I run our lung cancer screening program, and I have an interest in early detection of lung cancer research as well. Happy to be here. Thanks for joining.
Thank you for being with us today. Dr. Silvestri, would you mind introducing yourself?
Hey, I'm Gerard Silvestri. I'm a pulmonologist at the Medical University of South Carolina at Charleston. I'm Associate Director of our Hollings Cancer Center for early detection and biomarker research, and I'm also happy to be here.
Thank you for being here. Dr. Gonzalez, would you mind introducing yourself?
Hi, Anne Gonzalez. I'm an interventional pulmonologist based at McGill University in Montreal, Canada.
Thank you so much for being here. We are going to go ahead and get started. We are very thankful that you're all here with us today. Please make sure to send your questions in the chat box, question and answer box. Dr. Arelli is going to be checking and sharing with us the questions you have. So first question I have for the panelists is, I was hoping that they could share with us how they chose to include all the studies that they included and how they went about to update the 2018 guidelines to now 2021 guidelines, and what were the major changes that they found?
Sure. Yeah, thanks for the question. I'll start. If you haven't participated in guideline development before, it really is quite a process and an education on what it takes to make sure that your recommendations are truly evidence-driven. So this guideline was an update from 2018. And the starting point, it's typically to formulate some questions that you want to answer through your literature searches. This time we called them key questions. They're called PICO questions sometimes, where there's patients, interventions, comparators, and outcomes. And you do that because that's what you want to cover. And then it also helps to frame the literature search that follows. So in 2018, there was a literature search around all of our key questions or PICO questions, and then we filtered those down. This was a very different process in that the lung cancer screening guidelines were one of two CHEST guidelines that were chosen to be living guidelines, meaning every 3 months, we repeated the literature search from the 2018 publication. Gerard and myself would look at those and see if they were relevant, the articles that came up in the literature search, relevant to one of the key questions, and to decide, would they likely make a big enough impact to change any of our recommendations, at which point we would want to update those guidelines. So this was every 3 months, 2 of us looking at it. And then really what pushed us to update was we knew that the Nelson trial, one of the big lung cancer screening controlled trials, was going to be reported. So we were prepared that when that trial was reported, we'd be ready to take another look and update the guidelines. From there, we have a study methodologist who helps abstract data from all of the new articles, who helps to do the meta-analyses for the key questions that have enough literature to do a meta-analysis for. We have a panel of experts with broad expertise, from surgeons to implementation scientists to pulmonologists, chest radiologists involved. And we all reviewed some of that literature, came together, crafted the new recommendations, voted on them formally. We had to meet predefined thresholds for yes votes in order for those recommendations to be accepted, and then crafted the document. It then goes through review at the Guideline Oversight Committee. It goes through review with the journal. And so quite a process, but well worth it, I think. Gerard, did you want to add anything to the process before we go to
No, I think you've covered that completely, Peter.
Yeah, and the process is the most boring part too, right? So we should move on. The next question really was most important, I think, was what really changed from 2018 to 2021's guidelines. There was new literature, particularly supporting lung cancer screening. The Nelson screening trial was the second after the National Lung Screening Trial that was powered to detect a mortality benefit. And nobody was quite sure if it was going to. It enrolled slightly lower risk individuals, the National Lung Screening Trial, but it did. And actually that benefit was even greater than in the National Lung Screening Trial. So that new bit of evidence allowed us to strengthen recommendations and to look and see if we could broaden eligibility criteria. In addition, there was 3 more years of practice, right? 3 more years of implementing high quality lung cancer screening for us to consider when deciding on the balance of benefits and harms. I'm not sure, Alice, if you have the first few guideline recommendations, maybe we could put those up and I'll just highlight a couple of the differences there and then ask Gerard to comment. So we broke up the recommendations into who you should screen and then how to perform high quality screening as a program. So the first recommendation is worded the same as last time: screen people age 55 to 77, 30 pack years or more that they had smoked in their lifetime and they've smoked within the last 15 years. With the additional evidence to support screening, that was moved up to a strong recommendation from a weak recommendation that last time, and moderate quality evidence. The Nelson trial screened down to age 50, and a few other studies have as well. And our meta-analysis suggested there was benefit more than harm going down to age 50. The Nelson trial also had a lower pack year threshold for enrollment. So the evidence suggested that we could recommend screening to a broader group. So the second guideline or our recommendation statement is entirely new. Age 50 to 80, smoked 20 pack years, and you've smoked within the last 15 years. This had less evidence to support it, so it's a weak recommendation, but still what we're recommending. That first recommendation matches what Medicare currently approves as policy, and they're relooking at their policy. They'll have new guidance out probably in February or March of next year. And that second recommendation is in keeping with what the United States Preventative Services Task Force has recommended for eligibility for lung cancer screening. The third recommendation statement here, some may say it's new as well. I think it's more a lesson in the importance of choosing words and language than anything else. Last time we made our recommendation said that we wouldn't routinely screen people who have a high enough risk based on a risk calculator. And what we meant by that is there are variables in those risk calculators that like age and smoking and history of a prior cancer and COPD that end up identifying a population at higher risk for competing mortality. And therefore, we might identify a lot of people who shouldn't be screened because they're not well enough to be screened. And so we worded it that way. And then in our remarks, we said, but we recognize there's some high-risk people who are well enough and you should consider screening them. And I think the remarks sometimes get lost. This time with a little more evidence, a few more risk calculators looked at in different ways, we chose to kind of flip the language. And here we've said, if you don't meet those first two criteria, but you're projected to have high net benefit from lung cancer screening based on the results of clinical risk prediction calculators, combined with life expectancy estimates, or based on a life year gained calculator, then we suggest annual screening, weak recommendation. So it's not really much more open than the old one was, but it's framed differently, phrased differently, where that I think will draw attention as being different. Notably, there is no policy. This is our recommendation. So the USPSTF doesn't recommend the use of calculators. Medicare, I'm not sure what they'll decide, but I'd be a little surprised if they do recommend calculators. So this comes with remarks that include thresholds on the calculators for you to consider as high enough risk, but it also comes with a remark saying, hey, insurance may not cover this person's screen because this is our recommendation, not some broader policy. So I'll leave those comments at that. Open up, Gerard. Was there anything else?
So I would just add, yeah, that was wonderful, Peter. I would just add a couple things. One is the Nelson trial in Europe. One of the reasons that people were a little bit hesitant was the only trial ever powered to answer the question was national on-screen trial. So getting this second trial really did increase our recommendation. The other thing about the Nelson trial is their control group was no screening at all, no screening, as opposed to NLST, which had a chest X-ray. The third difference in those trials, which is worth mentioning because it's come up, especially to me in a few questions, which is, hey, the Nelson trial, which was only 13,000 patients compared to the 53,000 in NLST, really didn't see an overall mortality benefit. They saw a lung cancer reduction in mortality, but not overall. And I think the reason for that is that it just wasn't powered enough to show that difference. The last thing I'll say is that and these were, this is not sort of definite yet, if you will, but in both the NLST and particularly in Nelson, women did much better than men. Now, 85% of the Nelson trial was done in men and 15% in women. And so when the article came out in the New England Journal, they actually had them analyzed separately. But man, in both studies, women seem to do a lot better than men. We don't exactly have an answer for that right now, but it's something to consider when you're talking to patients by gender about their screening. So that's, I think, I'd just leave those few extra comments in there.
Dr. Silvestri, would you mind clarifying for me if women did better in terms of mortality from cancer, or yes, they did better being screened?
Better from a mortality benefit. I don't have the number right in front of me, but it did better from a lung cancer mortality reduction. In NLST, it wasn't statistically significantly better, but there was a pretty good trend. And in the Nelson trial, it was a fairly sizable difference, but they were looked at separately.
You had, I think, a slide that summarizes the various risk ratios. Yes, this one here. And you see at the bottom there, male and female, this is across all studies. So benefit to both, for sure. The risk reduction was 0.88 in men and 0.69 in women. So you see a stronger signal for benefit there. I just wanted to mention as well, because it's been an issue that in the third recommendation was meant to support this concern, that the standard age and smoking history-based criteria it's been shown that they can selectively disadvantage certain groups, particularly minority groups, and the risk calculators may help to equalize opportunities to be screened as well. So that was another reason that we chose to, state this in the affirmative rather the other way around.
Peter, I totally agree with that. I would add that if you look at the JAMA articles around the United States Preventive Services Task Force, they did 3 articles appear. One is the actual article itself that makes the recommendations. The second is a modeling study. And in that modeling study, they take on a few of these things, particularly race, and then editorial. And the editorial talks about disparities and race. And what I would tell you is, if you put the same, I've done this, put into calculators and you put an African-American with just a bit less smoking history, 20-pack years as opposed to 30, but same age, same everything else as a white person, you'll see that the African-American wouldn't have been able to be screened in the old criteria, but actually had a higher risk of developing cancer than the the white person in that. So I do think that using risk-based screening sometimes can really uncover patients who would not normally be eligible that would then become eligible. And so again, one of the reasons they moved USPSTF down to 50 and 20 pack years is that African Americans develop a lung cancer at a younger age with a less smoking history than their white counterparts.
Thank you so much. This was excellent. Dr. Gonzalez, do you have anything to add?
Yeah, I guess my question to both Dr. Mazzone and Dr. Silvestri would be, how do you implement that third recommendation into clinical practice, right? Which model you would use, or how do you go about, I guess, trying to use these calculators that are better at predicting, especially in women, in African Americans, but then perhaps those individuals may not be covered for lung cancer screening. How do you reconcile that?
I think it's a great question, and it's not easily answered. It comes back to a bit about what's the purpose of a guideline like this with these recommendations. And unfortunately, we don't make policy. We can't make insurers cover things that we suggest. That tends to go to the USPSTF and CMS. So we hope by drawing this out and making a recommendation that it helps to move those needles over time so that you can offer screening and be assured that it's going to be covered for individuals. But that's not where we are now. At your individual program level, some programs are very, very strict. If you screen outside of current guidelines and policy, you're not going to get paid, and there's always been kind of a question or fear of being punished. So I think you have to understand the local insurance space and what your institution is willing to do and what you're not. The second part of it, and I think maybe some of the reason why policy is stuck to age and smoking history, is the risk calculators aren't simple to use. It's already difficult to get people into screening programs. And now you're asking for a few more variables to be entered into a calculator and to have a threshold. So you have to design and build your program in a way that allows those calculators to be used. We calculate the risk during every shared decision-making visit in our program. We have a centralized program and a nurse practitioner seeing these patients and entering that in. If we had to rely on the primary care provider to do that calculation to refer to our program, it would be very unlikely to happen, no matter how much support we provide within our electronic health record or otherwise. So I think it's on us as a program to reach those patients. We're trying to encourage primary care to refer to our program, and we can help make those decisions and do other types of lung health care. All of the calculators are that we suggest, they have online tools, so it is doable for sure. And we provide in the remarks, I don't think they're included in the slides here, thresholds for risk of developing lung cancer on each of the validated calculators that you would consider to be thresholds of, as it says here, high net benefit. So we're not trying to identify those borderline cases here where, shared decision-making may suggest it's not the best thing to do for that patient. These are people who clearly have more benefit than harm. The other challenge in implementing, if you use a pure risk prediction calculator and not the life year gain calculator, you also have to estimate life expectancy. And life expectancy in the remarks from some of the experts who are part of our panel is 10 years. Some studies have suggested 5, others 10, but 10 years is what they're saying. And that's not an easy estimate to make either. So there are challenges to implementing this, but we do think it's the most just and equitable way to deliver screening at this time. Gerard, what do you think?
Yeah, I would just add that our program also is a centralized program, and we use the Tamamagi model, and we individualize risk for every patient. And I will say that for patients who come in that don't meet the current criteria of 55 to 77, the current CMS criteria, but have a risk that's above what the Tamamagi model says is reasonable. And some of ours are way above that. We've been offering them screening. We offer them a reasonably priced CT if they can't get coverage. We tell them they may not be able to be covered, but they're at a higher risk than the general population for developing cancer over the next 6 years. And one other thing, insurance questions have come up so much in these discussions, but one other thing I would say is that once a person has an abnormal scan, then they go right into their regular insurance. So for the most part, it's that first scan that might not be covered, but if they have an abnormality along RADS 3, 4, they would get covered after that. We like the idea of individualizing risk because it also gets to the shared decision making. If someone's closing in on 77, they have some other, they've quit smoking 14 years ago, they have some other health problems, and their risk is really below the NLST threshold or the Tamamagi threshold. We stated that this might not be a benefit, so it really becomes very personal for that patient at that point. So we like the models. I would agree with Peter. You're not going to be able to get a primary care provider who has a 15 or 30-minute office visit who's dealing with diabetes and back pain and other issues to be able to sit down with a calculator with those patients.
Vineesha, we have a comment from our audience. Do you want to share that?
Absolutely. And I also wanted to say for everyone who's able to be part of the Journal Club today, please pass on all questions. At any point, I'll be able to interrupt and ask a question. But we have a great one from William Graham. And he's saying, according to the American Lung Association, Massachusetts has the highest rate of LDCT screenings of eligible citizens in their state, but it's only 18%. On average, across the United States, only 5% of eligible patients for LDCT are actually screened. What does the panel think we can do to increase screening rates? While broadening the age and criteria for screening is great, it seems that the main challenge is getting screening to be done in the first place. I think that's actually an excellent question. So, Dr. Mazzone or Gerard Silvestri, what do you guys think?
Yeah, I think there's two main problems, and I think that the entry into screening, though, is definitely a problem. I think some of the numbers are a little overstated. The 5% number, comes from data collected in 2015, right when Medicare actually started approving lung cancer screening, and we've seen numbers go up from then, and accredited centers go up a whole lot from them. Then those are also kind of questionnaires to patients who may have got scanned for different reasons, and they're answering and not quite sure if it was screening or not. So it's helpful to know that data, but I'm not sure it's all that accurate. Dr. Silvestri has a paper soon to come out that shows by 2019, the American College of Radiology's registry had 1.2 million people screened out of 8 million eligible. So you can see the percentages are higher than suggested, though still far poorer than we would like. So the second challenge, and identified in multiple ways, including in that study, is getting those who are screened to come back. In any 1 year, we may only screen 5% of those who are eligible, though over time, the percentage who are screened is much higher. So adherence has become more clearly a major issue in performing high quality screening. What should we do here? I think it's education of your community, of your providers. It's making things as easy as possible. Our program overnight had a 4-fold increase in referrals when we had a best practice advisory go live in an electronic health record. It just can't be on the primary care provider to remember it. has to be somehow right in front of them to allow them to identify everybody. We're taking additional steps now in scanning smoking histories in our record and sending messages through our MyChart communication system with patients, trying to allow them to self-schedule. It's how can we get this to be as easy as possible? We started screening on main campus, and now we're at 11 sites around our health system, bringing it closer to the patients. This has been an up and down issue, but some patients can't come in for their shared decision-making visit. Can you do it through telehealth? You could during COVID, but those rules are getting changed again. So how can we make it as easy as possible, but yet still maintain all of the quality of the program that you want? And I think there's a lot of tactics that we can do to implement things. Gerard?
Yeah, it's fantastic, Peter. I think I'm going to add a couple more issues. So one of the things in looking at those first million screens is that it looks like more current smokers are being screened than former smokers. And boy, that's not what the National Lung Screening Trial showed. And so one of the things that's different, there are a few things that are different about lung cancer screening that make it challenging. The first thing is, if you look at colorectal screening or breast screening, it's basically just all citizens of the United States of a certain age, maybe plus or minus a family history, but you're going to get your screening, age 50 for colorectal, unless now it's actually recommended down to 45, unless you have a strong family history. It's easy to remember that it's everybody. For lung cancer screening, it's making sure you have to have this pack year history and this age history, and then a quit history. How long ago did they quit? And so I'm wondering about why former smokers aren't getting screened. And it might just be that internists, if the person's not smoked in 10 years, it might be sort of out of sight, out of mind. They just, they quit smoking a long time ago. And, so I think identifying the at-risk population is difficult. There have been multiple papers that show that the electronic medical record is highly inaccurate at identifying pack years. And so that's one challenge. There's another sort of hidden, two other challenges I'd put to you. There's one hidden challenge, which is smokers reside in a portion of the population that may not have as much access to screening as non-smokers. Why do I say that? Well, if you look at the smoking rates in the United States are about 15% across the board. If you look at people with less than a high school degree, that's 25 to 30%. If you look at people who make less than $35,000 a year, it's also much higher. And so these people generally can't identify a primary care provider. They don't have health insurance sometimes, or they have Medicaid, which is not always covering screening for lung cancer. And so they reside in a portion of the population that doesn't generally have as good access to screening as for example, other screening services like colorectal or breast cancer screening. And finally, there's the stigma portion of this. Many patients feel like they brought this on themselves. They don't want to talk about it. And so we have to get around the stigma of screening for cancer. I think Peter's right, though. It has to be a full-out blitz if you're going to increase screening. Everything from PSAs to talking to your internal medicine groups at your institution, any way, shape, or form. I mean, look, like breast cancer screening has really increased in the United States. They get 300-pound football players to wear pink gloves on Sunday, right? Like, it's an incredible thing that women have done to increase breast cancer screening, and I applaud them. Unfortunately, what they should also understand is more women will die of lung cancer in the United States than breast cancer. And that's true probably in Canada as many other places. So probably need to start getting that message out as well.
Dr. Gonzalez, do you have any other ideas to increase screening?
Yeah, the perspective here is a bit different because within a single payer system, where certainly in my province in Quebec, Cancer Care Ontario has been ahead of the curve in Canada, but in Quebec, screening is still in its infancy with sort of a government-run multi-site pilot project. We had a pilot project at my institution run by a colleague. And so what's happened, in fact, with some of the delays in getting these more official programs, off the ground, has been ad hoc screening with GPs ordering scans. And that creates all kinds of problems that are beyond the scope, I think, of the discussion, but like, the wrong criteria, having studies that are not low dose, et cetera. So yeah, the perspective is a bit different, but the interest in there and things are certainly getting off the ground up north.
Dr. Mazzone, I was hoping that you could talk to us also about this finding on the number of surgical procedures for benign disease that you found.
Yeah, so the evidence that we were looking for when making recommendations included, is there evidence of benefit? And the counterbalance was, what are the evidence of potential harms from lung cancer screening? Screening is unique to what we do. We often see someone with a symptom or feeling bad, and we do tests to try and help make them feel better. Here in screening, these are folks who come with no symptoms, they're feeling fine, and now you're doing something that could harm them in some ways, whether it's the screening test harming them themselves or our evaluation of the results. So in lung cancer screening, most of the harms come from finding lung nodules or things in the lung that need further evaluation. And so we stress throughout the guidelines in the implementation part of how important it is for programs to have high quality lung nodule management, to follow protocols and algorithms, to have all of the proper personnel and tools available to help manage nodules. And this particular harm question was, how often do people with screen detected lung nodules who end up having a surgery, how often does the surgery happen in somebody with a benign nodule? And you see quite a bit of variability there, but the sum was about 22% of the time. I believe in the lung cancer screening registry, the ACR registry, it was even higher than that, 28 or 29% a year or two ago. So 1 in 4 surgeries is done for benign disease. Add to that sometimes surgery is done for cancer that may not need to come out. A ground glass nodule, an adenocarcinoma in situ that may or may not have hurt that person over time. There's a portion of surgeries for cancer that maybe didn't need to happen either. So this is a major consideration when you're implementing your screening program, is how are you going to minimize surgery for benign disease without delaying the time it takes to take out an early stage lung cancer. And there's lots of strategies. I'm sure our own program, we have a category 4 nodule tumor board. We meet weekly and review all the category 4 nodules from that week with chest radiology, pulmonary, sometimes thoracic surgery involved. And we find we often end up downgrading the nodules from category 4 to lower categories. And we're able to have a very low percentage of our surgeries be for benign disease, but definitely something that can impact the balance of benefits and harms, and every program should consider.
Dr. Silvestri, you're mute.
I'm sorry, Peter, what would you consider as low? What would be reasonable?
5%.
Yeah, I don't know that we know that number. No one's ever sort of stated that as a number that we should have as a goal. I completely agree with you. But, a lot of places don't have a dedicated chest radiologist, for example. And so one of the things that we've tried to do is in our satellite hospitals, and we just started a screening program in Lancaster, South Carolina, which is incredibly small, rural, 100-bed facility without even a pulmonologist, Peter. And so we bought the APP down here, had them sit with our radiologists, our dedicated chest radiologists, and then we had a champion radiologist up there that agreed to format everything in lung rads. But any lung rads 3 and 4 does come, get a virtual visit here for that exact reason. So one of the things I would recommend to our audience, if you're not in a place with the ability to have a lung RADS tumor board, if you will, please try to get together with someone who does or who has experience with this. I think 1 in 5 surgeries for benign disease is unacceptable. It's absolutely unacceptable. It's one thing to put someone through the surgery and have them have a risk of dying perioperatively if they have cancer, right? It's completely something else if someone's goes through surgery and has a terrible complication from surgery with benign disease. So I agree the goal should be less than 10% and perhaps less than 5%. And I think this is one metric that programs should keep some of their own data on so that you can share that, with each other to try to improve outcomes in your own program.
Yeah, I think the other number that was produced in a different figure was related to procedures for benign disease, not surgeries per se, and that was 35 to 40%. Of all of the biopsies were performed on a benign nodule. So something else to work hard at minimizing, particularly in this population who are somewhat prone to complications from those biopsies.
And I would add, just remember that these are the randomized trials largely done in academic centers with expertise. And so I think we really don't have a great handle on community sites. And so again, this is, maybe even an underestimate. So I think we do need to keep that data at your own institution and try to do everything you can to avoid biopsies and unnecessary surgeries. And again, we don't hesitate at times to have a 3-month follow-up for our patients as opposed to going right into a biopsy just to see what happens to the nodule. One other thing, the Nelson trial used volumetrics to help them decide benign from malignant, and they recommend that as a way to follow up these nodules. We are getting more and more experience with that at our institution and finding it very helpful. It's a little bit difficult to do, and you probably need a dedicated chest radiologist, but the software is getting better and better. And volume measurements might be more accurate than sort of just putting your cursor on and pulling it across to see if a nodule is growing or not.
And it looks like we have another question from our audience. But before I get to the question, I just want to say, as a community pulmonologist, I think having the guidelines come out again and having them change and modified will definitely put it back on people's radar to be able to talk about doing lung screening, besides as pulmonologists, but as PCP. So this has been very welcome and very exciting information for those who are practicing in the community. We have a question from Ionis, who is asking, what do you suggest for non-smokers who may develop lung cancer? And I'm thinking she's asking specifically about how the guidelines may affect that or not.
Yeah, with our current understanding, a never smoker, someone who has never smoked cigarettes, won't ever reach a high enough risk of developing lung cancer to be included in low-dose CT screening. I think we've been fortunate, and I say that carefully. Probably the only reason we found a mortality benefit is because we have such a dominant risk factor. Unlike breast and colon, we couldn't CT scan and biopsy so many people, like everybody who's over 50 or 55. We would definitely end up doing more harm than good to the population as a whole, even though we'd find more cancers and fewer people would face late-stage cancer. We would just hurt too many people to help the smaller numbers that we find. So what might happen down the road, there's a tremendous amount of work being done on biomarker development for lung cancer and pan-cancer early detection, some very promising stuff. Technologies have come a long way, and it's now in the eye of funders and venture capital, and they see this is a field that can help a lot of people, but also be profitable for business investment. So I'm optimistic that some of these blood tests over time will allow us to broaden the pool of eligible individuals for lung cancer screening, but that's still a few years off or more.
Yeah, I think there's also the part here where, you do get some worried patients who come in who lost a parent and an uncle and an aunt, and even though they've never smoked, they are very concerned. They want to be screened. And I think one thing I would ask our audience to do is to talk to them about the potential downsides of screening, which include, these things like surgery for benign disease, and include things like biopsies that can lead to side effects such as pneumothorax and bleeding. So, I try to reassure them that their risk is incredibly low. I actually put them into a model if we need to, and discuss that, show them the risk there compared to what the risk of an average smoker who would be in that. And we don't screen those patients. We tell them they're not eligible, and we don't screen them. Now, it does turn out that, some of them go across the street and find a radiology unit and, pay out of pocket and get screened. But I'm just not going to provide that care. I try to do everything I can to be empathetic and listen and try to reassure, but we're not going to provide care that we don't think is necessary and that might cause more harm than good. So that's a conversation I think is worthy of having with a patient.
And we have another question from our audience. Are there guidelines dedicated to specific occupational exposures?
There are no guidelines specific to those exposures. Those exposures are included in a few of the lung cancer risk calculators. They're often hard to quantify or verify that a significant exposure has occurred. So unfortunately, they don't in and of themselves raise somebody to the level of being able to be screened with current policy, but they can enter some of the risk calculators and add to the risk there.
Yeah, the NCCN, the National Cancer Care Network, had a second sort of non-evidence-based recommendation that if someone was younger or may not have quite the smoking history, but had a quote exposure, and they list things like asbestos in that you might want to go ahead and screen them. But we have not taken the tack of using that. We would put some of those extra exposures into the model, right? Into the model, and if it raised their threshold over the threshold where screening is recommended, then it's in the model, and we can justify that. I will say, and Peter, as editor-in-chief of CHEST, I'm certain this article crossed his desk, but the group from New York City looked at screening in their World Trade Center, the folks from the World Trade Center, and one of the things they found, these guys were exposed to a tremendous amount of dust and other particles during the World Trade Center debacle, and it did look like, and they were also smokers, but it did look like they had a fairly high risk of developing lung cancer, higher than you would expect just based on their age and pack-care history alone. What to do with that data, I don't know. They were getting screened either way. Those workers, health workers, or those workers, frontline folks were getting screened either way through the fire department in the city of New York. I don't know what to make out of that.
Dr. Gonzalez, do you have anything else to add?
No, I just wonder with the time left, if you want to have tackle some of the key implementation messages from the guidelines, perhaps.
Absolutely. I just want to add something to what Dr. Silvestri said in terms of the World Trade Center. We're also hearing not only lung cancer, right, but all other cancers, also a lot of multiple myeloma, also not related to their age. So it makes it very hard to add those type of exposures to a broader guideline that would cause a good, like a beneficial impact in the population, right?
Yes, the answer is yes. Look, it came up before. How can we increase the proportion of the population that's being screened? And even if Peter and I are slightly on different sides on how many people are being screened, is it 5%? Let's say we double it to 10%. It's still not nearly enough. And so we can split hairs and go after these other smaller groups, but that's not really what's going to make big headway from a public policy standpoint, from a reduction in mortality across the United States. Is we got to really focus on getting the people who are eligible into programs. I did see, and not in the chat box, but there's a couple of Q&A questions from Boutros. Can I take those on?
Yes, if I could just read them to everyone, because I thought they were actually excellent questions. And the question was, what is the acceptable timeline between a positive study and a definitive treatment for malignant findings? And then I also thought the next question was excellent. Who is best suited to champion the program, a pulmonologist, a radiologist, or a thoracic surgeon? So please.
So I'll answer the second one first. Of course it's a pulmonologist. Come on, guys. This is what we do. No, look, I do think pulmonologists are really well suited to running one of these programs. Why? First of all, they can really assess, even without a risk model, they can really assess whether their patients would benefit from screening. We see these patients with COPD on oxygen that may not benefit from screening. Second is we're also there to evaluate and manage solitary pulmonary nodules. So we're good at that, and we should not shy away from that. And radiologists aren't, generally used to having a shared decision-making conversation. And thoracic surgeons in general have a bit of a perverse incentive to run a screening program where they might, want to operate more than is possibly necessary. So, yes, I'm biased, but I do think a pulmonologist is an excellent person to run that program. By the way, an advanced practice provider can do such a terrific job with the program, and we have one who, is under the auspices of 2 or 3 pulmonologists here. Then the acceptable timeline is, look, a positive study, it depends a little bit on their LUNGRADS designation. If they're LUNGRADS 3, it's 6 months to follow-up CT. If we have definitive malignant findings, those patients ought to be managed quite quickly. And so for our LUNGRADS 4s, we are getting them in for either a biopsy or PET scan or even surgical resection if it's a nodule of high enough pretest probability to be cancer. So we want those patients taken care of quickly. The whole point of screening is to find these patients early so you can resect them and they don't advance. So what's acceptable? I don't know. We have a rule in my clinic that a new potential lung cancer has to be seen and have a plan within 10 working days. We don't always meet that, but that's our goal. They come in, we get them an appointment within 10 working days, and their workup shouldn't take much more than 10 working days after that to they either get biopsy or receive definitive treatment. It's a goal. It doesn't happen every time, but if you don't have goals for your program, it's not going to be the best run program.
Yeah, I think just to add to both those answers, the first, who should run it, and I don't disagree. Pulmonary is in a great place, but you really have to be interested and passionate about it. It's a lot of effort and a lot of collaboration that's necessary. And whoever runs it needs the other groups to be part of it for it to run well. We wouldn't have a good program without our chest radiologists' interest and involvement for sure, and having all the other folks to manage nodules. The other question's a tough one. We had some quality indicators developed and asked that question, and we had answers sort of all over the place. And one of the challenges is it's not often a metric that's kept. Time to treat is usually from the diagnosis of cancer to treatment. And there are some studies showing, 30 days, this and that. But rarely do they include time from first noticed to time to diagnose. And if that ends up being long time, that could impact things just as much as getting someone in for treatment really quick. So, I think it's something that you should track and aim to have as low as it can possibly be, but the best number is hard to really define.
Yeah, and just to add, I was being a little facetious. I agree with Peter. If you are really passionate about this and really take the time to build a program, it really doesn't matter. Good leaders are good leaders, no matter what their subspecialty is. And so I want to make it clear. And we are so multidisciplinary here that we couldn't do it without. And I will tell you that we provide feedback to our chest radiology group, which we've now kind of honed down to less people who provide more standardized lung rads, but we'll actually have them go back and amend reports after tumor board to reflect what the true lung rads is, because that affects patient care as well. So, you know, being responsible and accountable to each other is very important, but having a team with good thoracic surgery support, good radiology support, a great nurse navigator, they're all important.
I think the metrics too are really quite nuanced. I mean, time to treat a ground glass nodule that we know is an adenocarcinoma in situ probably doesn't matter, right? And so if someone's penalized because that took 2 years till it was diagnosed and treated, you know, that would be wrong. So we just have to be careful on how we measure these things and apply them in practice.
And I just have 2 more questions from the audience, with being mindful of the time, but they're excellent questions, so I want to make sure we get them out there. One is from William, and it's actually directed to Dr. Mazzone, but I'm sure Dr. Silvestri and Dr. Gonzalez can speak on this also. You mentioned earlier on the webcast that CMS is reevaluating coverage for LDCT eligibility in February and March of next year. Can you give any more details about that? And obviously this is based on the challenges they have with getting insurance coverage for the LDCT.
Yeah, I don't have any insight into where they're going with it. I think we're hopeful or optimistic that they're going to change to match what the USPSTF has recommended. So lower the age criteria, currently 55 in CMS, to 50, and the PAC years from 30 to 20. I don't anticipate that they'll embrace risk calculators, but maybe I'll be wrong there. They did have a period of public comment, a period of public comment already. Then they'll probably release draft recommendations and have another period of public comment. So you can be on the lookout for those. Some in the community wonder what they're going to do with some of the other mandates, data collection, shared decision-making. The lung cancer screening community is kind of on both sides there. Some think shared decision-making may provide a barrier to uptake of screening, and others feel it's very important. I think both Gerard and myself have strongly favored in continuing the mandate for shared decision-making, and that is one of our recommendations. But I don't have more insight as to what they'll decide, only the time frame in which they're going to make that decision. Yeah.
It's hard for me to imagine that they'll go against the USPSTF. I don't. Peter and I both have been at different times in touch with the people at CMS. They're going to be very deliberate about their decision. I'm not completely optimistic that we'll know by, February or March, but we may. The one other thing I'll tell you is once the USPSTF makes that recommendation and once CMS covers it, the other insurers through the Affordable Care Act basically have to cover it. So I think what you'll see is once that happens, it will go down very quickly to the insurers. What I would tell you also is we've seen some insurance companies willing to cover already down to the 50 based on the USPSTF's recommendation. So you may want to at least check with your local providers.
And most of our local providers have already accepted those new eligibility criteria, which was great. So it does help to know what's there in your community.
And real quick before we wrap up, and I thought this is another excellent question. Again, this goes to Dr. Gonzalez, like Mazzone, Dr. Silvestri, anyone. As we know, smoking cessation should be prior to referral to LCS. Are we seeing that done? And if so, to what extent? They're curious about LCS and smoking cessation rates, and if we're seeing that's enrolling more patients.
Yeah, I mean, the practical answer for your own program. I think it's absolutely mandatory to have a smoking cessation connection, whether you train your providers to provide high quality smoking cessation guidance or you're connected to other programs in the community. Absolutely, you shouldn't be screening without having that as part of your program. In our guideline, what was just put up there have been some studies that looked at the impact of screening on smoking cessation, and it tends to be favorable, though not dramatically so. And the smoking cessation rates are still far lower than you would like to see.
Yeah, I'd add a couple things. We had our APPs trained in, so at first we were just referring them to a smoking counselor, smoking cessation program in our university. But we found that it became very clunky and inconvenient. So we sent our APP to be trained and certified in smoking cessation counseling. So they can do the shared decision making, they can do the follow-up of the nodules, and they do smoking cessation on the ground. And we found that very helpful. I would add two other things. One is there are 8 R01 level National Cancer Institute trials called the SCALE trials at 8 institutions. Ours happens to be one of them, looking at how to best incorporate smoking cessation into the screening visit. And so we should be getting data soon on those. They're about 2 to 3 years into those, maybe even a little bit more. The second thing I would say is, listen, these are your recalcitrant smokers. Think about it. When you look at smoking cessation trials of varenicline or other things, they're taking all comers, 30-year-olds, 40-year-olds, people who binge smoke on the weekend. We're talking about people who largely have smoked a pack a day for 35 to 50 years. These are people that are intensely hooked on cigarettes. And we have a manuscript that's being submitted right now where we looked at NLST and detailed smoking information, and it looks like some of these about a third of them need a cigarette within 15 minutes of waking up in the morning. About a third of them, right? And so we also found in that study that if they were treated with double therapy, nicotine replacement plus varenicline, actually it was Wellbutrin in that trial, they had a much higher chance of quitting. And yet in the national unscreening trial, of the people that were in that trial, that were eligible, only 25% received any kind of nicotine replacement. Think about that. Current smokers, 25%. That means 75%. Now, maybe they just said they didn't want it, but if you look at the surveys of those people, 75% never got any kind of nicotine replacement. We're dealing with a highly addicted group, and we have to, I think, come out of the gate swinging if we're going to get those folks to quit.
Thank you so much. Unfortunately, we are running out of time. This has been a great discussion. I was hoping that we could get each of you to give us one take-home point from the new guidelines that you want people to stick with. And again, on behalf of CHESS, thank you so much for coming in and for all of those who called in from home. So how about we start with Dr. Gonzalez, then Dr. Silvestri, and then Dr. Mazzone.
Yeah, I think for me, the main message, of course, beyond the importance of this living guideline and to know that is keeping up to date with the evolving data is to see what comes next. I look forward what comes next in terms of the evolution of the criteria for lung cancer screening, the use of biomarkers, and certainly being more on the investigation side to see how we could really work on optimizing the investigation and minimizing invasive procedures in our patients with benign nodules. I think that's a really important part of the process. So I look forward to what comes next.
Yeah, for me, the thing that I'm most interested in, and I think it's going to be the most important single challenge in screening, is getting people to come back. Adherence. If you look at multiple different trials and looking at the first million screens, only 22% come back. And that's National Unscreening Trial, 95% adherence. In the Nelson trial, 95 or a little less than 95% adherence. There's been one study, a modeling study, that showed if your adherence drops to 46%, that's double what we're seeing now in the community, you lose about the 50% of the efficacy. Remember, if you have a screening and it's a one and done, you screen and you don't find cancer, you still have to do that follow-up and come back to find those cancers. So to me, that's the big challenge. And I want everyone to reiterate that to their patients. This is not a one and done. You need to come back for your follow-up exam next year.
Yeah, I think I'd ask everyone to take away, we had two parts to the guideline, and one is who should you screen, and you can debate things, you can look at the evidence, and, we came up with the best we could. But I don't know that any of that matters if you don't look closely at the other half of it. And it's how do you implement high quality screening so that you're providing benefit to as many as possible and minimizing the harms. Any of you who are proceduralists, and if you've ever had a complication and it was for nod, it was a benign nod. I mean, you just, it's hard to get over sometimes, right? We just have to do this well, and then criteria can loosen, we can get more evidence, so on. So I would just ask that you closely look at not just who you should screen, but how you should do it in order to keep this moving forward.
Amazing take-home points. Thank you so much. And again, on behalf of CHEST, thank you for joining us this afternoon. Bye, everybody.
Thank you.
Thank you.